perform seizures. So when a neurologist thinks about seizures, I describe them as they're like an electrical storm of the brain. So when people, and your children may have had EEGs, and so what is that test? So basically what we do is we put electrodes on the scalp. And so number one, you have to realize that the scalp is out here. We're trying to measure electrical activity on the surface of the brain. And so it's really hard. I mean, we can put electrodes on the surface of the brain, that's a possibility, but we don't tend to do that very often. So you always have to realize that there's some interference, or there's a limit to what the test can find. So that's first off. And so you basically put electrodes on certain locations on the scalp, and you try to detect electrical differences between certain electrodes in the brain. And so everyone kind of has kind of what I call a wavy EEG pattern. Some people have what we call sharps or spikes, and those are what I like to call brain irritation. So an irritable brain will send off sharps and spikes. And if you start doing that repetitively and frequently enough, that's what we call a seizure. So even when they put EEG leads on patients with Pelizaeus-Merzbacher disease, they really were unable to document the sharps and the repetitive nature of those. Another part of the nervous system that could be contributing to the spells that people see is the autonomic nervous system. And so there's the sympathetic and there's the parasympathetic. And sympathetic is basically fight or flight. Parasympathetic is rest and digest. Very, very simplified. And so as you can see, there's neurons that come from brainstem, go they're along the side of the spinal cord, and they send nerves out to things like eyes and lungs and heart and GI and salivary glands. And so if you have a change in the nervous system there, that may contribute to some of these spells that we have, especially with changes in heart rate, changes in breathing, and the increased secretions, which again can all happen with seizures, but may not necessarily be an actual seizure by our definition. So basically, we're not exactly sure what causes the PMD spells. A lot of people think that they're subcortical seizures, so the seizure may originate so deep in the brain that we just can't find it on the tests that we typically do. That's a possibility, especially because what we call the subcortical part of the brain is the white matter, and that is the part that's affected in people with PMD. Is it just autonomic nervous system instability? That's also a possibility. Triggers, I know some families think there are triggers, others don't, and so I'll leave that up to you guys. What we generally do about these, if they are a really big problem and they keep people from doing things, or people are worried when they happen and the ambulance keeps getting called, is we typically have in the past have used a medicine called carbamazepine, which is the drug name for Tegretol. It's one of now the older anti-epileptic drugs, and it works on sodium channels. But it can decrease the number of spells. That said, the spells don't always have to be treated. Again, if they're not bothering people and we just live through them, then because this medication has side effects like all medications do, you have to kind of weigh, is it worth it to be on the medicine versus having the spells. So how do we go about diagnosing PMD? I know that I touched on this briefly yesterday. Number one, you have to think about it because it's typically not picked up on our general testing that we do. It's not something that is on the prenatal screening test. It's not something that your pediatrician is looking for on a regular basis. So number one, people have to think about it. Number two, it typically leads to getting an MRI. And the MRI can change over time as the MRI changes with all children. And so it can be missed more easily if the MRIs are done too early, specifically before 9 months. And then once we get to a positive MRI, the next step is to order a gene test. There is specific gene testing for PLP1. People typically start with the duplication testing because that's the most common. If that's not found, then they move to gene sequencing, and so they look for the single letter changes in the genetic code. That all said, there are people who have been clinically diagnosed with PMD where it's been we've been unable so far to find a mutation in the PLP1 gene. So our gene testing isn't 100% perfect at this point. Now, granted, it's a lot better than it used to be, and I think it keeps getting better. But I like to raise the possibility that it's possible to have PMD and not have a PLP1. That says we get smarter. I get more nervous about making those diagnoses without a gene change. So what does an MRI look like in someone with PMD? So this side is normal brain MRI. Again, we've got gray matter, which on this sequence is, because it's a T2, is actually lighter than the white matter, which is supposed to be dark. And then this is a same image, same slice, and again, this slice is going through the brain like this. You can see that, basically it's all there. Like if you were just kind of looking through very quickly, nothing like really, if this is what you're looking for, nothing really would stand out. What you have to realize, though, is that this, in quotes, white matter is actually white on this image, and it's not supposed to be, and that's the problem. So you can see that basically all the areas, you can have dark lines, in through here, are all very nice and white on this image. And so that shows that there is basically substantially decreased myelin and a bit of inflammation in the white matter of this brain. The more severe side of things, people who are more severe than the classic, is called conatal, and that's when symptoms are present right away at birth. And I think this gets to be a difficult thing, and I basically start not really caring so much if people are diagnosed with conatal versus classical, because I've met families who their child clearly fits with classical, but they picked up symptoms right away because they knew, because they had a family history, or they were just really observant parents. So just because you see symptoms right away doesn't necessarily mean it's the most severe. But traditionally, that's how doctors would think of this, is if you saw symptoms and someone noticed on day one, then it would probably be the more severe form. And then on the other side, you may not see symptoms until late childhood, even early adulthood. Even though, looking back, people with SPG2 often are not great in gym class, they don't do well in sports, they have difficulty keeping up with other kids their same age. They may also have the dysarthria and some of the ataxia problems. And bowel and bladder issues tend to be more of an issue in people with the SPG2 type of the spectrum. This is the reason why I get really nervous these days about diagnosing someone with PMD without a gene change, is that there are lots of leukodystrophies where you don't myelinate very well to start with. Not necessarily that other leukodystrophies you may myelinate and then lose that, but these are all where you early don't myelinate well. And again, this list grows on a fairly regular basis. And so I think it's important for, if you don't have a gene change, to think about other things. Now, what do we do as far as treatment? I think the number one most important thing right now is nutrition and breathing support and therapy. And how we are able to do these things is to control the spasticity. And I'll let Dr. Young talk about the orthopedic management, because that's it's a critical part in both breathing and being able to move. So people who are on the growth chart, and I was talking to a few last night, it's not about having your weight on the growth chart. It's about having your weight be proportional to your length or your height. So you want to be, if you're 25th percentile for height, then you want your weight to be somewhere between the 5th and the 25th percentile. And, having too much weight is also a problem. And this one is an issue because people who are underweight or don't have good nutrition get sick more often, have more bone problems, and it can just cause a lot of problems. That said, if you get on the other side of things, you have low tone, you're not controlling your muscles very well, you have more of it to move around, that is also a major issue. Yes, ma'am?
However, the ratio that you said was a good window again?
So I don't want people to really focus on what is the length, what is the weight. It's looking at the weight to length ratio in the little kids or the BMI in older kids. And you'd like your BMI or your weight to length ratio to be above the 5th percentile, but probably not above the 50th. So somewhere between 5th and 50th percentile for the proportion. So I would like people on the slender side, but on the chart.
When does BMI become more of a factor?
There's BMI charts once people get to be 2 years old. You can start using BMI at that point. Before that, you have to use weight to length.
You said pulmonary, what are you talking about? Like the spray, the inhaler, and then the little nebulizer, yeah.
Well, so people with this have what my fancy word, floppy airway.
Right.
So they have difficulty breathing. That's where it gets the stridor. But you also may make too many secretions. And if the secretions then get into the lungs on a regular basis, you have trouble breathing. And I think Dr. Stevens is going to talk about that quite a bit as far as treatment-wise. But it basically becomes a snowball over time. So it's not really a primary lung problem. It's the neurologic problems end up leading to lung problems.
And then you'd be more susceptible for pneumonia.
Yes,
right?
Absolutely. And controlling breathing or helping keep the secretions out of the lungs, keeping food out of the lungs, all of those things help with pneumonia. But also having good nutrition helps with that too, because your immune system works better and you're able to fight off infections. And you're also able to withstand more.
Now, will somebody show us what's the best way for them to sit up? I'm just asking, what's the best way to keep those secretions from going down?
A lot of it is about positioning. Some people have suction machines. Some people will actually use medicines to decrease the secretions.
Like Mucinex or something, right?
There's a whole long list of medicines that can be used to decrease secretions. As far as spasticity, we typically will start with oral medications, so diazepam, fancy word for Valium, baclofen, dantrolene, tizanidine, and then there's some dopamine agonists, which we use more rarely. I like to point out with the oral medication is the goal of all of these medications is to decrease your tone, period. So you take it by mouth, it goes everywhere. It's going to decrease your tone everywhere. And so you have to be really careful in people who have a mixed tone picture with these medicines, because while they may have really bad spasticity in their legs or their arms, their trunk is probably still low tone. So whatever tone you have there, you're going to decrease that even further. And so you have to really be careful, because decreasing the central tone can actually lead to more problems, even if you are fixing the peripheral spasticity. And so one way we try to get around that is to use botulism toxin injections. So, it's the stuff people get in their face, so you can't move your face. Similar to when we put it in lower extremities or upper extremities. It basically paralyzes the muscles It makes them easier to stretch. So it makes therapies easier to do, and some people then require casting to basically lengthen and get their joints back into alignment if possible. There are surgical procedures that also come into play when managing spasticity, and I'll defer to Dr. Myung about those. Yes, Dr. Hobson talked about research extensively last night, so I will not go over that. Dr. Walsh wanted to point out that there's a website called clinicaltrials.gov. Anybody can get on it anytime. I'm pretty sure he did this within the last few days, but these are the research studies that are currently listed for Pelizaeus-Merzbacher disease. So number one, there are research studies. Great, which there didn't used to be very much. Many of them aren't taking patients anymore, but again, they're there, and people are working very diligently on finding a cure or a more effective treatment than just basically putting Band-Aids on the problems. And then I thought this picture would be nice to look at. This is I think from the umbilical cord transplant study. And so, they talked about making the myelin, that people would actually generate myelin. And so you can look at the pictures yourselves and see the difference. Now, you have to look pretty closely. So this is before transplant here, and they're pointing out what we call the posterior limb of the internal capsule. And then right after transplant, you can see that this is slightly darker than it was here. And then they did this one out a few months, I think actually a few years later, and they showed that they were able to keep it. So overall, the myelination pattern looks very similar between those. However, you can say that the posterior limb is slightly darker here. Now, so it's very, very minor changes. However, all of the neurons send their white matter through the internal capsule, and so myelinating here is actually a really important place to do it. But again, what they've been able to do thus far is pretty minor changes. And then this is a patient who has PMD who's not been treated, and this is where I think that MRI study would be really important, because as you can see, this MRI changes over time without treatment at all. And so I think you get to know how things go generally without any treatment before we can say what works and what doesn't.
What's the timeline on that? What's the difference? What's the age difference?
This 9, 7, and I think he's 2 or 3 here.
So it's still not normal at 9, but has improved, correct?
Yes.
Without treatment, to
Yes.
some extent.
Yes. Yeah, still not normal, but there's more myelin there at 9 than there was at 2. But that's true for everybody, like everybody. You get more myelin as you get older. And like I said last night, myelination isn't done until people are 25. All right, I think that's the end.